giving a minute or two, just so that we can all start off together at exactly 7:10 p.m. So I think it's just about a minute, or actually, and then we can begin. Good evening again. I would like to welcome all of you for this evening's webinar. It's good evening for those who are in our time zone, and greetings to anyone who is joining us from a different sorry, I think I must have dropped off a bit. I will say again that I'm welcoming you to our webinar this evening that is on quality improvement in obstetrics and newborn care, a strategy that is set in place to end preventable maternal and newborn deaths. And this evening, as you can see, we have a rich panel. And I would just first of all like to begin by welcoming Dr. Serem, who is joining us. For those who are not aware, Dr. Edward Serem is a consultant obstetrician gynecologist, and he's the current head of division of reproductive, maternal, newborn, child, and adolescent health in the Ministry of Health, Kenya. So I would like to welcome Dr. Serem, if he has already joined us, to give us a few remarks before we invite our panelists and we can begin the session.
Oh, yes. Are you hearing me, the moderator?
Yes, we can hear you, Doc.
Oh, thank you very much. Thank you very much. Thank you very much for welcoming me. As I've been said, my name is Dr. Serem from the division of RAMCA at the Ministry of Health. And I want to take this opportunity to welcome all of you for this webinar on improvement of quality of care in maternal and newborn health. You all know very well that as a country, yes, we are building the momentum to make sure that we put acceleration to all the interventions in making sure that we reduce maternal and newborn health as part of the African commitments and also the global commitments in making sure that no woman during pregnancy or newborn dies during that particular process. So we know we have in our country, we still have our data is still wanting, and we therefore all of us have to bring all our efforts. We know this is a multi-sectoral approach in the sense that we really want everyone, to rally everybody to contribute. And on this, I want to thank Kenyatta National Hospital and the obstetricians, the gynecologists, and all the professional bodies who have taken heed and rallied to make sure that we do a lot of sensitization, we do a lot of advocacy to make sure that everybody knows that we are on this mission. We as a country, yes, have to do much to make sure that we contribute and reduce maternal newborn mortalities in our country. One of them is quality of care, and I'm happy now today you are going to talk about the quality of care. The others are quite varied because other things also contribute. Issues of referrals, issues of the workforce, issues of commodities, and the medical equipments and the others. But all in all, at this point in juncture, I want to thank all of you for joining this meeting, and I want to encourage the robust communication, and so that we can learn from each other, learn from the experts who are going to present in this particular forum, and we continue improving on quality and sensitizing each and every one of us to participate. Thank you very much, and have a fruitful discussion. Asante.
Thank you very much, Dr. Serem, for welcoming us and having us start off. And before we continue, I think some attendees might be wondering why quality of health? Why are we talking about this? Because we are all feeling like we work very hard in our different roles and our different positions in the hospitals, in the facilities, in the community. But actually, sometimes the work we put in does not reflect in the outcomes we get, because we know that a maternal death, even one, is far too many, and we still have high number of newborn mortalities, and that is why we're having these conversations now. What we have been able to appreciate or see at least is that there has been an increase and a consistently good number of clients who are attending antenatal care. For example, the statistics from even our KDHS have shown that 89% of our deliveries are attended by skilled attendants. And also we have 98% of patients who are attending antenatal clinic that is manned by skilled providers. And also a reflection of more than 50%, about 66% of patients are actually attending a minimum of 4 of those visits in antenatal care. So the question becomes, what happens when they get to our facilities and either they're coming in late or with complications, or we're losing mothers, or we're actually having newborns with asphyxia or complications which are related to delivery process. So these are the kind of questions that we're asking ourselves, and we want to see at which point in our journey of care do we need to target maximum efforts? What do you and I need to do in order to minimize the complications and the deaths that are resulting from any gap in our care? So at this point, I would like to invite our first panelist, who's just going to give us an overview of what quality is, what it means, why we're talking about it, just so that we can all have a good understanding as we go forward. And I'm really delighted to introduce someone who is not strange to us. This is Dr. Lydia Okutoi. She is an obstetrician gynecologist at Kenyatta National Hospital, and she's currently the Director of Healthcare Quality at the KNH, which is our national hospital. And there she leads efforts to ensure safe, patient-centered care. She's also the founding president of the Society for Quality Healthcare in Kenya, and sits in various boards and supports national initiatives through the Ministry of Health and also the Acquire Africa. Her work has earned her a 2023 Patient Safety African Award nomination, which is a recognition by the International Academy of Quality and Safety. It is a big deal. And a Presidential State Commendation, the OGW. So with us, we really have the quality guru and the person at the national level and also in Africa. And it's such a pleasure and a delight to invite her just to give us a brief overview of what we would like to just know about quality this evening. Karibu sana, Dr. Okutoi.
Thank you very much, Dr. Colleen. I don't know whether I'll be allowed to share or somebody's sharing for me.
This is Nelson. You can go ahead and share.
Okay. Great. Thank you very much. It's a pleasure being here. Thank you for the warm and kind introduction, Dr. Colleen. Maternal health has always been a place where we know that we can add some volume in terms of addressing its challenges. Being my background in obstetrics and gynae makes that to be a comfort place. And so I'm here with a background that has been introduced, KNH and Society for Quality Healthcare being the main push behind what I do, while I know Colleen is one of our coaches in Acquire. So thank you for being able to indeed share your expertise and your passion in matters quality and safety. Yeah, so just mine will be an introduction. I'm actually doing a curtain raiser for the main big things. So I hope we can follow along and just looking at maternal health and any other kind of improvement. We always ask ourselves, what do we want to get? What does a good product look like? What is quality? And so the quality dimensions that we consider that can describe service are what we call the STEEPC. That is care safe? Is care timely? Is it effective? Are we utilizing the resources well? And does everybody have access to it? Those who need it most getting it the most on matters equity, not being disadvantaged because of color, race, or anything, or disability. And are we giving it with dignity? And is it well coordinated? So those are multiple acronyms, STEEP. But when we summarize them into the main three aspects is, are you giving me care that works? Care that works will come in a timely manner. If you're supposed to give me some treatment, if I'm supposed to get Amstel, then I will get that active management of third stage of labor in a timely way within what is standard and stipulated. And so care that works is care that is given on time. So the main thing is, am I giving care that is according to a standard that is evidence-based and that is in our protocols? So does care work, and is it preventing harm? That I will not get any other effect, I will not get any disability, I will not have any injury during care. I will be prevented from infection. So that is care that is preventing harm. And will I live to tell the story? Then is it being given in a means that I can be appreciated as a human being? So those are the main three cardinal things, and those are what we are trying to improve. So in this slide, we just needed to appreciate that what Dr. Sarah mentioned, that we have to address all the building blocks, the WHO building blocks, which we are aware of, the health workforce, information, medical technologies, finance, mechanisms, and leadership. So all those need to be addressed, but we've seen that even when we invest in all those, even if we bring delivery beds and health workers that are okay, that are skilled and motivated, that will not lead to directly to improved care unless if we address the processes. And so that arrow in the middle, access, coverage, quality, and safety, is a big way of narrowing what is this, what we are calling STEEP. We are looking at converting those building blocks into desirable outcomes. And those desirable outcomes is that the healthcare will be improved. We will be more responsive. We will reduce the risk, the financial and social risk protection. It will be more efficient. The experience of the patients will be better. They will say they had dignified maternal care. So the essence of improving care is to ensure that all these things, all these buildings we're having, all these equipment lead to a better outcome. And the outcome of interest here is the ultimate, that to reduce maternal death. And that is why this series on maternal death and perinatal surveillance series is on, that we are tracking that outcome. But we're here also to demystify that in looking for that outcome, we have to address the processes. The processes have to be right and they can be tracked. Dr. Serem also mentioned about the different levels. So we address this at the micro level, that is at the facility level, then at the macro level, at the next level across maybe the hospital or across the county, then at macro is national. So we cannot only improve that one facility, but we need to improve then the referral systems. Then we need to improve at national level, we need to move the needle towards reducing poor outcomes, reducing mortalities. And so this slide just helps us to understand those domains. What I called STEEP are called domains of quality of care. It was defined when in 2000, it was noted that care was not good, but how could you define better care? Then they came up with those domains, but they are seen through various lenses. How does a patient look at quality of care? When they have been in maternity, they may appreciate that indeed they were given a warm cup of tea. They had a bath after delivery. How does the community look at quality? How does the payer, how does SHA look at matters quality when they come to see whether we qualify? The insurance companies, how do they look for quality? They are looking at efficiency, that we're using resources, they're paying for what is called value adds to their patients. What about the healthcare workers? How do they perceive matters quality within their space as they take care of the mothers and the children? So there are different lenses, and all these lenses have to be taken care of when looking at quality improvement. Government looks at coverage. They're like, Huko, you have a hospital. People of this region, you have this number of hospitals. So they will say that they have built the infrastructure. They say they have coverage. The distance from village to hospital is less than this number of kilometers. But is that working for the patient? So we have to look at all the multiple lenses when looking at quality of care. When we're improving anything, even in the labor ward, the board cannot just say you need to do this. They need to agree with the healthcare workers there, and it has to add value to the patient, and it has to be at a cost that we can truly invest in. And so one of the gurus of quality is Edward Deming, and he came up with what is called a system of profound knowledge. And this forms the basis of any quality improvement. He was an engineer, but he's one of the fathers of quality improvement. That first of all, for you to improve, there has to be measurements. You have to have a metric that you are tracking, and you track that metric. For example, of interest here, maternal and perinatal deaths. Those are what we are tracking, but we are saying we will track beyond just that outcome. We need to track the processes. If they're dying because of bleeding, then we have to find out what are these process measures addressing postpartum hemorrhage. If we are having delayed access to care from where they're coming from, what we call, is it the first a delay to do with awareness to reach facility, or just the distance, the second to get to facility? So what do we need to measure? What metric are we measuring? And they have this thing that is called variation. So Edward Deming, in the profound knowledge, the profound theory of knowledge, is that there are 4 things that you look at, that every process has a variation. There is none that is static. And that variation has an acceptable, normal, or upper and lower. And so we look at what outliers are extremely high or below, which are of our interest. For example, we say when there is bleeding beyond 500 mL after delivery, then there is a PPH. It is possible that you may have some 300, some 400, 7. So every process has a variation. So you need to understand what are called special cost variation. If you're having a certain outcome that looks different because of the limits given, then you address special cost variation. And for you to have quality improvement also, you have to deal with the psychology. What are people willing to change? Is there opportunity, a window that this problem has reached, a place where the emotions of the staff, the leadership are considering this unacceptable? So when there is a wind whereby people are willing to change, a quality improver utilizes that. For example, this series is drumming us towards looking at these outcomes, looking at them and desiring to change. So choose an outcome or an issue to address that is related to what people would consider as we don't like this. I would want to be associated with a change. So once labor ward, once certain department gets to a point that they consider something unacceptable, then they are prepared for it. So for you to change, you need the people, and the people need to have buy-in. Then you have to appreciate the system, that we do not work in isolation. By the time Bagathi is receiving a patient, maybe she has come from Kibera, antenatal care, maybe not having had consistently, maybe it is a teenager. By the time they are complicating and coming to KNH, we should be prepared that we are bound to get complications. So are we prepared with what this patient requires? It is not only the obstetrician and gynecologist, but for successful management of that patient, you need the blood services, you need theater that is functional, and you need all those team players to be able to be ready. And so an outcome does not come from an independent one person. It doesn't come from this one era, but there are multiple. So we have to appreciate that care is within a system and pack that system for you to understand where the gaps are. Then there is the theory of knowledge, where every technical person here comes into play, that they're neonatologists here. They understand what can possibly be done to reduce neonatal sepsis, what can possibly be done. So that theory of knowledge, it requires the experts to start posting that it is possible that if we adhere to the pathograph and if we are able to respond accordingly to whatever the pathograph is guiding us to on time, then we will reduce, let's say, our outcomes or neonatal or having birth asphyxias and having poor intrapartum care. So when you combine these three, then you have a prerequisite for improving the quality of care in an institution, because you are able to track, you're able to have the people, and you're able to unpack the system and all the factors that contribute to the kind of care that is there. And then you're able also to propose what is to change. And so Edward Deming becomes one of the very key thinkers on matters quality. And this is perverse. We have utilized it for many years and we continue building upon it. Another theory that comes from IHI was the triple aim that grew to quadruple aim. How do you look at quality of care? You'll say you have reached there. In America, it was to do with the cost of care. That when you're able to reduce the cost of care, then you'll be making it more accessible, it will be quality. And indeed, this week, we hear that our President Donald Trump has reduced pharma to some extent by even up to 80%. Why? Because that cost makes it difficult for quality of care to happen when medicines are super, super expensive. So addressing cost, looking at patient experience and at population health, addressing the social determinants for poor health, ensuring there is equity across the race, across the regions. Then they added taking care of the staff, the well-being of the caregivers, addressing work-life balance, workforce incentives. So this is also one of the model that enabled us to know what does quality of care mean. I once had an American friend who mentioned that when her mother was in labor, I think she comes from, she's Asian, she could not afford a cesarean section. So the mother labored for very long before this girl was born. And it was because of they had just come from, I think, Asia. I mean, they were first level immigrants, and so access to care because of high cost can be a challenge, and that is a mark of quality when care is not accessible because of cost is a challenge, and no wonder we are having UHC. So these principles that I'll share, 5 of them are from Deming. They are outshoots of what Deming shared in his theory, that for us to have improvement of quality of care, we need to have measurable change. And so you need to take a metric. For example, we're looking at maternal death, but we're saying we could have other process measures. We could have process measures like what is the number of patients being given Amstel. We could have those adhering to the preeclampsia protocol, depending on what is sensitive to that process, what is the turnaround time. So quality improvement we can only be systematic when we know that we're able to track and measure. And as Deming said, we have to know what are the factors in the system. What are the staff issues that are affecting this level of care? What are the patient issues? Because at times we have to prepare for the very sick patients. If you're in a facility and a tertiary hospital, we have to prepare for massive transfusion because of the kind of patients we receive. And so how are we ready to focus on our system issues to be prepared? Because the lower facility hospitals will not do that. So our conversation should be at that level of we understand this. We are prepared to have support in anesthesia that can withstand this kind of patients that may not present in any other place, but we have a chance that we can save them because this is the right place for them to come. I'll go to the side of the family. This third principle is to what extent are we involving staff and patients? And by the way, all these principles are part of the standards of quality of care by WHO, and the Ministry of Health also adopted it in the QOC, quality of care guideline for maternal and neonatal health. There is one of the standards there that is to do with the people. Are we engaging the families and the patients? How? With information. Can they anticipate what our commitment to them is? Those who require more information because they have long hospital stay, are we able to engage them? Are we able to involve them in their care? How and in what way are we ensuring that information is flowing, and that information they will continue using it at home? Because once you engage the families, you get a contract, they trust you, and so they're able to continue and utilize the knowledge that they were given. And how do we communicate when things go wrong? So we need to have the communication across the spectra. I used to feel very saddened when patients come and maybe they've come too late, and all we could say is, it wasn't our fault, you've come too late. The challenge is that patient is suffering, so we should feel their pain. How do we offer an apology on behalf of the system? We are so sorry you went to this facility and you didn't get help. You've come here, but unfortunately, maybe we lost the fetal heart. So do we also empathize with them? And are we able to give them opportunities to give us feedback and tell us where we could do better? Then another key principle is use of data, and not just use of any data, but data that can enable decision making, that we are having decisions that are data-driven. Data-driven decisions are the key to quality improvement. Otherwise, the rest can be rumors. So in quality improvement, data is key, and you choose data that can make sense to the people who are within that process, so that you track it with them and you make sense of the data. Focus on the teams. The teams are the front line and the ones that can support them, empower them to be the ones who will recognize opportunities of improvement, because the front line is where the rubber meets the road. And that is where care happens, and improvement has the emotional attachment to the patient. They see the patient at the higher levels, at the level of the HOD, the directors. They may not be as enthusiastic as the one who has the patient close to them. So the frontline should be empowered to generate the areas that should be focused on. They understand what is called the vulnerabilities and the opportunities of their process. They know what can change, and they listen to the patients because they are closest to them. So we should focus on empowering the teams to do quality improvement. And whatever has worked in Kiambu, because Kiambu, I'm told they have reduction of maternal mortality. They've not reported any for the year. We should have learning. And so thank you for this opportunity. We should have learning. What has worked in a certain hospital, in KNH, in MTRH, concerning a certain case, we should learn and scale it. And so this is both a local conversation and also a bigger conversation. That's just a summary of those key principles. But if we want to improve, what models can we use? There is what we call the lean approach. In the lean approach, the idea is to identify anything that is not a value addition to the customer and reduce the non-value add steps. So in lean approach, you want to ensure that the things that do not add value, the waiting times that are not necessary, you reduce. The wastage in movements, you reduce. And it's both just for the patient, but also for the processes. In labor ward, one good lean approach we did when we were in labor ward was to do with putting together the PPH tray, and I think it still exists. I've seen Professor Osoti here. Yeah, that PPH tray, people would reconstruct it whenever they require, look for a catheter here, look for a condom, look for misoprostol. So all that was put in one tray that you go for a one-stop. And so in preparedness, you'd have that together, and it would reduce motion and time wasting just to prepare something to respond to PPH that commonly happens. And so lean is one of the great approaches, because it makes the frontline healthcare worker be the one to add their voice that this is necessary and this is the quality of care that should flow. And this does not add value to the customer. So the customer has their position, but then also the frontline healthcare worker. Then we have the Six Sigma. Most of the time we combine Lean Six Sigma. There is about reduction of defects and in a systematic way, improving and being able to standardize it. These are things that we can look at further, but mine was just to mention. And my icing on top of the cake is the model for improvement by IHI. So this one is commonly utilized together with the PDSA. It is one of the very simple and logical approaches to quality improvement, that when you have, let's say, increased maternal mortality in a space, or let me use a process. For example, there is we are having a process of patients not being managed according to the protocol with regards to preeclampsia. So what could be the approach is we determine what do we want to improve. Do we want to improve adherence to the protocol? And what would change look like? Change would look like treatment beginning within a certain timeline. And so you take that as your measurement, and what change is required. Are the medications available? Are the staff aware? And so you determine the change that is needed, and you implement that change, and you continue measuring it. And so that is where the PDSA comes. You plan, you do, you study and act till when there is change in that metric, because our changes would want adherence to the protocol by the people the patient's receiving some medication within a certain timeline. And so we'll be tracking that timeline. So change is if we are able to have treatment that is initiated as fast as possible. That is just an example. So model for improvement is a powerful tool for quality improvement and can be utilized in any setting. And so there are also tools for QI, which we tend to use. We can have tools to explore the problem because you cannot start improving what you don't understand. And then also tools to communicate and tools for sharing data. And then there are also lean tools. I will not go into those details, but in quality improvement, there are many toolkits you choose depending on where you are, but I chose to put explore because unless you understand a problem by brainstorming, asking 5 whys, determining who the stakeholders are, have the conversation with the right people, and mapping out the process, looking at the customer journey, and putting a fishbone diagram. So you don't need to use all of them. But depending on the issue, if it's to do that process, then you'll need to draw a chart. But putting the right stakeholders in the room is the one important win that you will do. How do we benefit in quality improvement? There are improved outcomes. The patient also has improved experience because you involve them in the conversation. And they would want to have care that works with respect. They'd want to be safe. So they will benefit, but the patient outcomes, including reduction of maternal deaths, reduction of PPH, reduction of care that is not according to the standard. There will be improved efficiencies, reduction of wastage and errors, and also you'll be more proactive and not just waiting to respond to an outcome, but you will plan. Quality improvement requires that we are able now to make changes that anticipate when this happens, this is the approach that we will take. And so it helps us unpack complex problems and improve them in a systematic manner. Finally, just to give a remark that indeed it is important to recognize that all processes can actually be improved. You can do better. So regardless of how difficult or how far we think we are, I know we may not be having dashboards and fancy things, but that willingness to have the Wanjiku coming receive better care can help us use these tools to unpack a process that is challenging using what we say the STEEP, the domains. That is this care safe? We can address safety things. Is this care that is effective, that works? We can address that. Is this care efficient or wasteful? Then there is a gap there that needs to be addressed. Is this care that is equitable? Are some women not getting the kind of care because of some disability or because of anything that disenfranchises them, whether age or whatever issue? Then there's opportunity to do that, to improve that, and our patients getting dignity as they come for care. Are they in a clean environment? Are we talking to them with respect? Are we being abusive? Are we giving them opportunity, at least to know that they have support as much as feasible as it could be in Pumwani or in labor ward of KNH? In what way are we improving that person-centered, respectful maternal care? So all those are opportunities for us to unpack those processes and do the next best thing. Thank you very much. Allow me to end
Wow,
there.
thank you so much, Dr. Okutoi. You have been so generous with the information. You have given us quite a detailed overview about what quality is, every aspect, I think. So that was a lot of information, and it's actually been pardon? So I was
You are
just saying
dropping.
thank you for being very generous with the information.
Thank you, Colleen. I think you are coming in and out. I don't know whether you're back. I can see you're back.
Of what quality is. And really the principles that we need to apply and what governs quality, and is able actually to the standards which have been set both by our Ministry of Health. So next who will give us a pediatric perspective, what quality looks like. I would just like to invite Dr. Jalemba Alvala, who is a consultant pediatrician. He's a senior lecturer at the Department of Pediatrics and Child Health at the University of Nairobi. And Dr. Alvala is also a researcher. My interaction with him is with health systems research and implementation, where he's affiliated with the Kemri Wellcome Trust. So I'd like to invite Dr. Aluvala to just give us a perspective from the pediatrics. And also just to remind us, those who are in the webinar, to just put your questions in the Q&A section. If you have any comments, put them in the chat, any observations, so that we can see what is addressed during the presentations and what we can discuss after the presenters. Thank you. Karibu sana, Dr. Aluvala.
Sorry, Dr. Raka, I'm not sure whether it's my internet or it's yours. I seem to have lost you.
We can hear you, Doc.
Oh, okay, so it's Dr. Raka. Okay, all right. Perhaps in the interest of time, I can go ahead. So when she comes back, she can probably pick up from where we are off. We left off. So good evening, everyone, and greetings to anyone, other people who are in other time zones. So it's a really great pleasure to be here this evening, presenting work from a very large team of people who are very passionate and dedicated about child health. It is a privilege for me to speak after Dr. Kutori, who's a expert of international in matters quality of care and patient safety. So what I'll endeavor to do is just spend a few minutes to provide illustrations of how this team that I'm representing here today has worked over the years to translate those principles just eloquently presented into practice and practice in a way that actually impacts outcomes, clinical outcomes. So I don't think I need to repeat much of it, but just to reiterate the key issue there, when you're working in quality, you have to understand the context you're working in. And one of the most useful ways of understanding context is the concept of systems. So we have the healthcare system as we understand it, with the 6 building blocks and the processes that you need to put in place in order to achieve the health outcomes, health and other societal important outcomes in the society. So one of the key intermediaries for achieving these outcomes is quality, and as was already been mentioned, WHO has spent quite a bit of time thinking about how to translate those principles of quality that Dr. Kutari has talked about into a conceptual model that picks out the important components, and this is what you have on your screen on the left, on your right, which we have used in our work over the years. And I think the key message there is understanding that within quality, there are different elements. And one of the 2 big boxes we have is the provision of care that we are used to as healthcare workers, but also there's the experience of care that our clients undergo as a result of our actions. And recognizing that those 2 big blocks need human resources and other physical resources in order to achieve the outcomes at individual and facility level that we are all working towards. So what we have done in the work that I'm presenting, like I said, presents work from that started more than 20 years ago, and culminating in a network of facilities from 10 years, more than 10 years ago, which is named the Clinical Information Network, which you see on the map on your left, representing at its peak more than 24 hospitals, facilities from the general pediatric and newborn units in those facilities. And the aim was to work with this together as a team to make sure that the evidence-based guidelines that we have and the standards that have been defined by the Ministry of Health are implemented in order to achieve the desired health outcomes for the children that are being seen in these facilities. So moving from the facilities what approach does this network employ? So people may have heard of learning health systems, but and at the core of this approach is you have identify stakeholders, and then you have actionable information system, and then together with the stakeholders, the information system, you work together to improve the quality of care at individual facility level and at scale across different facilities. But one of the key things you have to remember is that the principles of quality may be simple, but the practice of it is actually quite complex. And just like if you use the biomedical intervention of, just like we always think about the treatments that we provide, what is the mechanism of action? So how do those elements, how do those principles work in practice? So you remember Dr. Tori mentions the principles of psychology, and because we are targeting behavior of either groups of people or individual people or organizations, we have to think about how do we appeal to these individuals and groups, and how do you motivate them to work together to achieve the outcomes that you're desiring. So that's the learning health system approach in a nutshell. So from here on, I'll illustrate what the lessons we've learned over time from those different components of WHO's conceptual framework on quality of care. So starting off with the provision of care in the general pediatric population. So we have this on your left. We are looking at graphs illustrating adoption of pulse oximetry use. So oxygen is a vital resource for ill children, and just like any other drug, it has its benefits and its harms, and it is an expensive resource, so it requires judicious use. So one of the tools that we have to allow that to happen is use of pulse oximetry. So you'll see adoption rate on the top left, starting from January 2014, and it does take time. Improvement does take time. And there are also the other key point that if you put together all the hospitals, you'll see a general trend in improvement. But a key lesson in quality improvement is that all hospitals are different, and then you can see in the bottom left there's variation in groups of hospitals, and then there's also on your right there's variations in individual hospitals. So if you take an example of Hospital 4 at the bottom there, they've achieved almost 100% adoption. Whereas if you take an example of Hospital 3, we are starting from almost zero, and they hit after some time, they almost went back to zero again. So it's food for thought, asking ourselves, as we said, this variation. So why does this variation happen? So another example from the newborn space. So the first example was an example of something you would want everybody to have. Here is an example of something that we don't necessarily want every baby to have, but you want only those who require you to have. So because of challenges in our diagnostics, people are following our clinical practice guidelines, and there's lots of antibiotics, and these are good example of from a good result that people are following the guidelines. But again, if you put together that these are 23 hospitals, when you look at individual hospitals, you find that there are also interesting things that are happening. So you'll find, like, take the example of Hospital 10, where we want people to use the first line, which is penicillin and gentamicin. That you have obviously something that is happening here, interesting happening, that whenever you have the increase in the first line, then you have a decrease in the alternative. And another example you see, if you look at Hospital 1, at some point in May 2022, they were actually, if you had third generation cephalosporins, was almost at 100% use. So aggregated data does hide sub-aggregated variation when you look at hospitals as units of study. So those are examples of provision of care in numbers. So not every aspect of quality can be measured in numbers. So moving on to experience of care. So we know that in the newborn space, maternal delivery of care is a very important component. So we are a bit ahead of the curve in this part of the world just because of the issues of resources, but increasingly across the world, it's recognized that within the ambit of family-centered care that we really need to work with moms. And this just illustrates differences of maternal experiences in different settings. So in the blue is the maternal experience in a public hospital, and in yellow, maternal experience in a faith-based hospital. And you can clearly see there the difference on who is delivering care and the kind of support that is available. This is an illustrative quote from a mom in the public sector. So it's not all doom and gloom. So good things do happen in the context of the challenges that we have. And you see this mom saying that they feel that the quality was good, but also recognizing that there's variation, that things are good during the day, but something does happen at night. So from provision of care to experience of care, let's look at illustration of human resources. Nurses are an essential, and in fact, I would dare say the foundation of delivery of neonatal care. And this work done by colleagues illustrating the variation in nurse to patient ratios, which is illustrated on the x-axis, and on the y-axis you have a measure of how much nursing work gets done. So the higher the nursing care index, the more nursing work has been delivered. And you can clearly see there's a virtual relationship where you have a better nurse to patient ratio, more work gets done. And you can see the distribution of where less work gets done because of the sometimes even more than 1 to 30 as a nursing patient ratio. So it means that nursing care doesn't get work, so they get done. So there are things which get missed out, which again is an important care component of quality of care and patient safety. Coming towards the end, so we've had the benefit of being at least 13 of our facilities within the network. I've had the benefit of being part of, I think, I dare say, a radical approach to providing resources, physical resources, because previously lots of things were being provided piecemeal without thinking about the integrated needs of the individual patient. So an individual patient would need multiple things. So if you, for instance, provide just a glucometer and you don't provide that baby who has jaundice with a phototherapy light, you will not necessarily make a difference. So in other words, you might not necessarily reach the dose required to achieve your outcomes. So there has been work done to scale this up, and recognizing that when you scale up equipment, it does create work, and so that again has to be a key element that has to be thought about. Finally, outcomes. So one of the key outcomes, we always hard outcomes, as we like to say in epidemiology, is mortality. So again, we've learned that in these facilities, mortalities does vary across facility and across different groups. So these 4 panels illustrate 4 different birth weight categories: less than 1,000, 1,000 to 1,500, and so on. And within each group, each dot represents a facility. So the line in the middle represents the median mortality, case fatality rate, and then the blue lines represents anything that is outside the blue lines represents facilities that are outliers. So remember the concept of common cause variation and special cause variation. So those who are above the blue line are doing better than expected, and those who are below are doing worse than expected. So the key, one of the lessons there is, whereas you expect you have the same population and you're supposed to provide them the same kind of care and achieve similar outcomes, contexts do are different, and because of those contextual differences, approaches to quality of care have to have insights on what exactly are the differences across place. So I'll finish off by acknowledging this large group of people. I know lots of them are probably on the call, and so there's a lot to be celebrated about this team. Lots of work has gone over the last 20 years, and particularly the last 10 years, working towards making sure that you do the best that you can for the children that you take care of in our facilities. And finally, acknowledging also the institutions which have been a key bedrock of support from Capricorn, Kenya Pediatric Association, Cambridge Wellcome Trust, the Ministry of Health, both at national and also at county levels, and finally the University of Nairobi, where I work, principal. Thank you very much.
Thank you so much, Dr. Aluvala. Thank you for that. That was a really practical example of how quality interventions are carried out, visualizing data, collecting the right kind of data and actually tracking it, and both quantitative and qualitative data. I think you've really highlighted an important aspect, and you've brought to life some of the principles that, Dr. Okutoi had already spoken about. So thank you very much. We appreciate that. And I am sorry, I think I was lost a bit when I was trying to introduce you. Clearly, the quality of my network provider is substandard, but I hope that doesn't happen again, yeah? And so as we go along, I would just like to continue to encourage you to post your questions. Some of the questions I've seen in the Q&A section have actually been addressed by some of the speakers. If we find any aspects that have completely not been touched on, we'll give an opportunity for those to be addressed. So I would like to invite our third and final panelist, who is Caroline Mololo, and she's going to give us the perspective of the midwives. So Caroline Mololo is a nurse midwife who has a degree in health system management, and she's currently the hospital administrator at Ruai Family Health, the Syokimau branch. And in addition to that, she has worked as a project manager and a technical officer with the Midwives Association of Kenya as a manager for the project, where she oversaw and coordinated all aspects of the implementation of the project on quality improvement in family planning, which was implemented in 8 facilities in Homa Bay and Vihiga County. So she has hands-on experience, she has the technical expertise, and she really brings in that experience as a midwife, and therefore she'll help us understand how we can bring these principles into the day-to-day practice in our labor wards, basically. So karibu sana, Caroline. Please take a few minutes and give us some insights. Caroline, welcome. You may proceed. We're going to give a chance to our technical team to just assist Caroline so she can be audible. Caroline, please check your mic.
All right, good evening. I hope you can hear me. Sorry about that. Colin, you can confirm you can hear me?
Yes, you can hear you, Caroline. Please proceed.
All right, thank you. Are you able to see my presentation?
Yes, you can see your slides.
All right,
You can
thank
put
you
it
so
in
much.
slide mode. Yeah.
Right. Yeah. So thank you so much for the invite, and thank you for having me as part of the panel just to discuss on quality improvement in the lens of midwifery. I'm just going to talk a bit about a midwifery lens on challenges, priorities, and solutions in regards to quality. And I will not go into details because the doctor has already mentioned what quality improvement is all about and not really what is expected of us. So let's share, kindly share for me because it seems to be affecting my network.
Yeah, Caroline, the network seems to be having a challenge. I don't know if there's something you're able to do.
Yes.
It's on now. I hope you can see my screen.
Okay. Yes, I can see it. All right, so we can go to the next slide. Thank you. Yeah, so we'll just go direct to, who is a midwife and what does midwifery entail in regards to quality. So a midwife is a healthcare professional specialized in women's reproductive health, particularly during pregnancy, childbirth, and the postpartum period. And in regards to quality midwifery care, we can define it as a skilled, compassionate, and knowledgeable care for childbirth women, newborns, family, encompassing pre-pregnancy, pregnancy, birth, postpartum, and the early weeks of life. So this care basically focuses on promoting positive experience, preventing complications, and ensuring the best possible outcome for both mother and baby. And so you understand that a midwife plays a key role in regards to improving the quality of maternal and newborn health. So quality health services provided by midwives, it holds the potential to improve maternal and newborn health outcomes and prevent maternal and newborn deaths. And that is one of the most important things, that we're trying to prevent maternal and newborn death. In quality improvement, we can also enhance healthcare processes and outcomes, including responsiveness to patient safety, effectiveness, timeliness, patient-centeredness, equity, and effectiveness. And these are some of the domains that the doc was able to share, even as she was introducing us to quality. So some of those domains, as we have mentioned, those are key to a midwife, and a midwife needs to be part and parcel of that. Some of the things that, a midwife, or importance of quality improvement in maternal health, of course, as we've said, to reduce maternal and newborn mortality, we understand that essential prevention of death is very important. Improving quality can lead to the significant reduction in the maternal and newborn mortality rate. If we are using the pathograph well, if you are able to see the antenatal mothers well when they come to the clinic, we are able to diagnose any conditions that would put the mother at risk, then, or the baby at risk, then we are able to intervene as soon as possible. So when we combine this, we are able to increase coverage of essential services like antenatal care and skilled birth attendants. Then in also improving service quality. Quality improvement initiatives focuses on enhancing delivery of effective health interventions through sustainable, collaborative, and cost-effective approaches. Because when you're able to give services that the clients can be able to pay for, then they will come back to the clinic. But when you're giving them services that they cannot afford, they would rather stay at home than come to the hospital. The other thing, of course, is addressing the health system inequitabilities. And once we are able to address this disparity in the access of care and ensure that all women and newborns receive the care they need, regardless of the socioeconomic status and the location, then we are able to improve our quality and reduce maternal and newborn mortalities. Also, just enhancing the patient experience. in regards to quality improvement initiatives, we can also focus on improving the patient's experience, ensuring that women and their families receive a dignified, respectful, and supportive care. So you'll realize that the midwife plays a key role in enhancing and making sure that the mother feels comfortable and has dignity. Have we had some challenges in attaining quality midwifery in Kenya? Yes. Some of the things that have led to this is one, shortage of skilled midwives, inadequate infrastructure and supplies, limited ongoing training opportunities, poor working conditions and burnout, then weak regulatory and supervisory mechanism. So these are some of the challenges that come making a midwife, or rather midwives not being able to attain quality midwifery. So if a midwife is motivated, they will be able to work well. Many midwives face challenges such as low pay, lack of career advancement and opportunities, an inadequate support system leading to decreased, job satisfaction and motivation. Also, some of the other things is a shortage of skilled staff, as we have mentioned. Like many other places or low-income countries, our country is still struggling with a shortage of qualified midwives, and this is impacting the availability of skilled birth attendants. The other thing is inadequate infrastructure. So many health facilities, particularly in the rural areas, you will find that they lack inadequate beds, the spaces, and the essential equipments, and even drugs, which are hindering the quality of care. Some of the other things is in inefficient training. I can say in regards to the training opportunities for continuation of professional development. This can also hinder the midwife's ability to stay abreast of advancement in midwifery practice. Everything is changing. And even as things are changing, we need to keep up to date so that we are not using the old mechanisms or the old things that were there. So it is very important for us to note that could be some of the challenges that midwives go through in order to attaining a quality midwifery, and especially in Kenya. The other thing that I would like to probably talk about is what are some of our proposed solutions in regards to this. So one, of course, policy and investment reforms, community-based approaches, technology and innovation, professional empowerment and advocacy, then of course a robust monitoring and evaluation system. This will enable us to be able to reach and to be able to have everybody who is working at our maternity areas to be people who are equipped with knowledge and skills and are able to do what is required of them, and hence improve our quality in regards to midwifery. So when you come to, maybe if I can just talk about implementing protocols to reduce medical errors and infection. You see, this can involve standardization of practices, involving communication, ensuring adequate staffing. You realize that sometimes someone has trained as a midwife, but maybe they are not working in maternity. They are working in another department. And then you find someone who is not a midwife is working in the maternity. So if we could have recruitment and retention of the midwives in where they have been trained, this would really enhance improvement in quality in regards to midwifery. Then improving the patient flow by streamlining the processes and reducing the waiting time. If we could come up with ways to involve optimization of workflow using technologies, training staff, coming up with numbers or coming up with a system that will enable patients to flow very well to our facilities, this will enable us to reduce the waiting time. Some of the indicators that the patients rate us on, one is the waiting time or the time that they spend, whether to see an obstetrician or a midwife. They will say they took a lot of time in the hospital. Remember, this woman wants to come finish whatever activities that pertains to her coming to the clinic and go back and do her other activities. The other thing is reducing hospital readmissions. And how do we do that? This is through follow-up care and patient education. When we are able to provide timely and effective follow-up care to our clients and educating our clients about their condition and ensuring proper discharge planning, the patients are able to manage whichever, if they're supposed to be taking drugs, for example, a client has hypertension in pregnancy or diabetes, they're able to take their drugs effectively because they understand why it is important for them, and so will reduce the readmissions. And as we continue following up our patients, we'll be able to tell them what they're doing, whether it's right or wrong. The other thing is developing and implementing standards to improve midwifery practices. We need to come up with ways of standardizing all our practices so that if someone comes to a refuge, if they go to a private hospital, Mata, they go to another place, Kenyatta, they would find the same standards are being implemented. Again, this will involve, creating guidelines for specific procedures, using tools to track outcomes, and engaging in an ongoing evaluation and improvement plan. This will enable quality to be standardized across the areas of midwifery and in every aspect of obstetrics and gyna. So the key aspects, as I have mentioned, which I don't want to go back because Doc already mentioned earlier, the key aspects of quality improvement for in a midwife's perspective. One, I will talk about patient-centered care. We realize that midwives prioritize the individual needs and preference of a woman, ensuring that care is tailored to her specific circumstance. In an instance, for example, we normally say that a mother should deliver in the same bed that she has been laboring on. But you realize we still transfer a mother from stage 1, we take them to the delivery bed. And sometimes that goes against what the client wants. So if we can come up with ways where the patient is a center person, then we can be able to design our labor wards in a way that will be very efficient to our patient. We have some areas which have actually tried to do that, like in Kapenguria, West Pokot. You'll find that the mother will labor in the same bed and deliver in the same bed. The other thing is evidence practice. Integrating the latest research and best practices into midwifery care, it's very crucial for improving our outcomes. Like right now, when we are able to use our pathograph in monitoring mothers in labor. Once we monitor your mother using a pathograph, in case of any deviation from normal, then we can be able to intervene as soon as possible. The other thing is continuous learning and improvement. Midwives are actively involved in identifying areas of improvement and implementing changes to enhance the quality of care they provide to the clients. So every time you go back to school, every time you read, even like right now, the way we are teaching and learning, we are all learning and we get more information of what you didn't have. So continuous learning and improvement is very important. Then last but not least is focusing on safety and outcome. So the quality improvement efforts are aimed to reducing risk, preventing complications, and providing outcomes for women and newborn. So as much as possible, you need to focus on safety and the outcome. You want a good mother, you want a good baby. You do not want to have a mother who goes home without a baby, and you don't want a baby to go home without a mother. So we aim at reducing any risks and preventing any complications that might arise. And of course, as I talked about evidence-based care, you see, we know that walking around in labor ward will enhance descent of the baby. So if we can allow mothers to walk around in our labor wards, having a companion, having someone to be with them, not giving drugs unnecessary, also avoiding cuts unnecessary, having a doula or a birth partner who can be with the patient, this will increase a lot of evidence-based care to our patients. And then, of course, intervening when necessary. This will also reduce, every time clients just going for cesarean section, we can be able to take up as midwives and do a midwife-led childbirth. Every woman should be given a chance, unless, of course, we have complications that might arise. Then, as I just finish up, is for us is to just to improve on everything as midwives so that we can be able to grow together in the profession. And as I conclude, quality midwifery is key to reducing maternal and neonatal mortality. We know that nurses or midwives are the backbone of any health facility. So as midwives, when we improve on quality, definitely we are going to reduce maternal and mortality. Then, of course, sustainable improvement requires a multi-sectoral effort or approach. We cannot work alone. We have to work with the obstetricians. We have to work with other cadres. We have to work with the pharmacists, with the lab technicians. So it needs everybody on board. Then empowering the midwife. Let the midwife be empowered and be strengthened so that they can be able to execute their mandate as midwives in the areas of work. So thank you so much. I believe I have shared what I could in most of the things had already been shared. Thank you.
Thank you very much, Caroline Mololo. We really appreciate that. You have actually gone through what it looks like on a day-to-day. And also you've done a very good wrap-up for generally just the principles and how to approach it practically. So we really appreciate that. And our time is really spent. We may not be able to talk about each and every question. Some have been answered, but I think it's important to look at some of the aspects that have been highlighted through the questions that were sent. Some people have asked about, behavior change. How do you influence behavior change? Because we're looking at the staff who is providing the quality of care, also as well as the patients. How do we also lobby or get buy-in of leadership and also government? Because policies are there in place, but how do we translate them into the infrastructure and systems that actually support the highest quality of care to our patients? So I just want us to remember, like from all our presenters, Dr. Kutoy, when you talk about quality, think about STEEP, think about the ecosystem and collaborating with them. Think about the data, the kind of data you need and you require, what you're tracking and how you want to change it. And I think I like what she said, that any process can be improved. So I'd like to invite briefly again Dr. Edward Serem to just give very brief remarks before we close. Dr. Serem. Is Dr. Serem here? If not, we can proceed. Okay, thank you. So ladies and gentlemen, I would like to acknowledge that we have come to the end of this webinar for today. I want to believe this was just an introduction to what quality of care conversation is about when we talk about maternal and newborn health. And I hope that we are going to have many more that just go into the details of all those things that have been highlighted and what we have received as feedback from the attendees. And at this point, I would just like to invite Dr. James Amenge, who is going to appreciate our panelists, the speakers, and all those who have made this engagement today possible. Dr. Amenge, you are welcome to give a vote of thanks and close.
Thank you very much, Dr. Colleen, for such a wonderfully moderated session. Ladies and gentlemen, this has been a successful day. We can never say enough thank you to the team that have shared their hearts out with us. Quality of care is a very central determinant in our outcomes, whether it is morbidity or mortality, and it cuts across our healthcare space, from patient satisfaction to patient outcomes. We can never run away from it. And it calls for a very unbiased conversation in our every level, which then includes all stakeholders. So allow me to thank Dr. Serem from the Ministry of Health, and just to appreciate the immense support that he's continued to give, and his leading role. Probably, I think he's basically showed us what it means to lead from the front in matters maternal mortality, reduction of preventable maternal mortality, and newborn perinatal outcomes. The WENE discussion has taken everyone by storm because of the kind of work with his team. Our panelists, Dr. Kutoi Messinia, I can never thank you enough. This team is grateful for creating time to just share your skills, just to share your perspective in what quality of care improvement would really look like. Dr. Luvala, as always, thank you so much for sharing your work with the team. And I want to believe that having put in perspective and just being able to show that indeed we can actually put these things in place, monitor them, and look back and say, what can we do better, and therefore make it to improve at every level. And Caroline Mololo, thank you so much for the insight from the midwife perspective. And I just want to emphasize the importance of having the right personnel for the right job at the right time. And how I wish at this point equally to mention the immense, the importance of the private sector equally taking lead in this component in ensuring that the right human resource is actually put into perspective, including public institutions. We still have so much that we need to be able to do. Thank you into making that. Our moderator, great Colleen, thank you so much, Daktari, for making it a worthy discussion and being able to keep us on toes, listening to every presenter. Our attendees from every corner of this country, thank you so much for turning out. Thank you so much for listening in. You've kept present until the end. We are so grateful for that. The Intercounty Initiative, our own Madam Mary Maina, aka Moscow, and the team from the 5 counties of Nairobi, Machakos, Muranga, Kajiado. We are so grateful. And every county that I may not have mentioned, we are so grateful because from your thoughts, from your every word, you made this conversation be possible, and you made it possible to actually put things on the table that every mother, every newborn is important. And until we can avoid every preventable maternal mortality and every preventable perinatal mortality, we can never rest at all. Our sponsors, thank you so much, Ampli PPHI, the consortium of JPIGO, PATH, FIGO, and COGS. We are so grateful that you are able to come to support this webinar, and we want to look forward, definitely better conversation, but better collaboration. And we're basically saying we open our doors to further conversation that can help improve the outcome of our women who are pregnant and our young ones who are being born amongst our midst. National Hospital, University of Nairobi, you've been a great host since we started the series on the MPDSR. We are so grateful for your continued support. Allow me to just mention Nelson. We may never thank you enough, the work that you do behind the scenes to make these things work. Thank you so much. Just from us, we appreciate you. This is a beginning on quality improvement discussion on MNH. Please don't tire. We still have 2 more sessions that are going to come, and we are going to be sharing this as they get planned and materialize. Look forward to them. Please tell a friend to tell a friend. Let's have a conversation. Let's all be involved. Let's remain accountable at every level, whether you are the team lead, where you are the person who mkono, as we call them, at every level. When we remain accountable, when we remain true to the cause, we should be able to actually move the needle. And moving the needle will not be happening like the way manna dropped for the Israelites. It will only happen when each one of us pull our weights and do something towards it. So thank you so much, ladies and gentlemen. We are so grateful that you stuck with us. Let's continue the conversation even beyond this discussion. Let's move this onto our places of work. And with that, thank you, everyone. And I would want to release each one of us at your convenience. God bless. Thank you.
And I would like to say a great thank you to the team that has presented today. It was indeed wonderful and engaging presentations. For those who are asking about the slides, please note that we have shared them through the chat. If you haven't received them yet, kindly note that I will be resharing them for the next 5 minutes. And this session has been recorded and will be uploaded to KNH YouTube page, where you can also find previous sessions of this MPDSR series. Thank you once again for joining us today. Do have a wonderful evening. We are still staying on for the next 5 minutes as I am sharing the presentations for this particular session. For those who missed out, kindly just stay tuned and you'll see them being shared on the chat box. Thank you once again and have a good night.
Good night, good beautiful people. Good night, everyone.